Imagine the scale of this challenge. You are trying to measure a human quality clinically, empirically, without losing the magic in it. Shane Sinclair is the founder and director of the Compassion Research Lab at the University of Calgary. He's also a professor in the Faculty of Nursing and an adjunct professor in the Cummings School of Medicine. Shane Sinclair is my guest here in the Toronto studio. Hello to you.
Hi, thanks for having me.
Thanks for being here. There's something really interesting about this work having a lab devoted to it, because I think it's, on the face of it, compassion would seem to be kind of maybe a nebulous thing, hard to pin down, hard to measure. Walk me through what you do at the Compassion Lab.
Yeah, so at the Compassion Research Lab, we like to say that we're advancing the art and science of compassion. And the reason for using those two descriptors, art and science, is because, to your point, I think it is very much something that we feel is intuitive. It's something that we just bring. It's something that's just natural. But at the same time, and looking in the world that we live in certain sectors of healthcare, it's maybe not as natural or as apparent sometimes as we'd like to think. And we now know that there's actually a scientific sort of base to compassion research. We're discovering some things in terms of the science and the evidence behind it. And so we're trying to merge both of those things and to honor the art of it, that it is something that is a human element, at the same time not taking away the magic, by making it overly sort of scientific or sort of ticky-boxy, if you will.
Right.
And actually merging those two things together and saying, how do we do that integrally in a way that honors the topic and honors the people that are involved in that compassionate relationship.
How do you measure it? I'm going to circle back to your lovely phrase, the ticky-boxy aspect of this.
Yeah.
How do you measure whether compassionate care is being offered, is being delivered in the healthcare setting?
I think we first need to start by making sure we're asking the right people about their experiences. And what we know from most compassion measures is that the existing compassion measures is that they were primarily from the perspective of the giver, of the healthcare provider. So it was about me coming in as a nurse or as a physician. I visited, let's say you. I walked out and said, how compassionate was I? How able was I to understand your particular needs? Which might be helpful, but I think it's a far cry.
I can spot the glaring hole here, and I'm not a professional.
And I think the comparator that I often like to give is it's sort of like going to a restaurant and you're going to do a Google review, but the waiter takes it away from you and says, now, that's not your job to be doing that as the customer. It's my job. I'm going to tell you how professional and how helpful I was. And so you have to make sure that you're actually asking the right person. And so the measure that we developed, it is a patient-reported measure. So I would say, much like we say about pain sometimes, that pain is what the patient or the person tells us it is. I would say the same about compassion. It is what that person tells us is if they're experiencing compassion, I should say. Because sometimes even my best intentions or what I consider to be compassion might not mesh with what you actually need and what you consider to be important and how you experience compassion. So
what might go into that measurement? Pain is an interesting analogy because I've seen the little charts at one end, a fairly like a literal happy face, and at the other end, a face that's, clearly in some agony. What are some of the things you're able to measure when it comes to a patient-driven gauge of how much compassion did I feel?
Yeah. The research that we did was qualitative. So as other people have said, qualitative research is sort of data with skin on. And so they would say things to us like, I can inherently know or intuitively feel when a nurse comes into the room and they are compassionate towards me. It's something I can sense. It's something I can also observe in the way that they look at me, the way that they interact with me, the things that they do for me. And so we have a large sort of qualitative foundation that then went into sort of developing that measure. It's a Likert scale, so sort of a scale between agree to disagree with a number of points in between it, and a patient or a family member is able to sort of say, did my healthcare provider treat me as a person and not just as a patient? They're able to respond to that, which taps back into that thing of seeking to understand? Did the person understand things from my perspective? Did they provide care in a gentle manner? So it kind of taps into all of those different aspects of, it's not just the warm and fuzzies, the intuitive feelings of a person coming to the room. It's not just a whole bunch of hugs and, that sort of thing. It's not just simply action and doing things. It involves what I would call maybe a concert of things that need to kind of be working in tandem in some ways.
This gets very real and very personal, I think, for a lot of people. I love getting a hug from a doctor. My sister would run out of the room screaming.
I would run with her.
Yeah,
potentially. Yeah.
So can it be a fine line? Can someone, there must be so many ways this can go wrong.
Yeah. I think sometimes, and I would say research is as guilty of this as anything, is we do dumb down, I would argue, compassion to sort of this touchy-feely thing when it involves, according to the recipients, but also to the responders, the healthcare providers that we've talked to over the year, it involves understanding. It involves understanding who you are and what you need and how you experience compassion. And it also involves wisdom in terms of, okay, how can I best meet those needs? Am I the person that can best do that? Or do I need to kind of consult or hand off to somebody else, for example, within the healthcare team? So the understanding component, I think, sometimes gets lost in sort of what I would describe as just this bolus dose of kind of like untargeted kindness that just is sort of a shotgun approach. But I think,
and that's not effective. That's
not effective.
Good.
And I think it's not effective to the person receiving it. But I think on the other end, it also can cause burnout among the responders, among healthcare providers, of sort of like needing to be everything and everyone.
Are there stories that stay with you as a result of all your work in this, from people you've encountered, patients, nurses, doctors?
Yeah, I mean, so many of the qualitative interviews, like that's the stuff that I've really liked, of sitting down and talking to patients and
Let's
sort of
get
saying,
into some of that.
I remember a person saying to us, you could blindfold me, they said, and bring in 5 healthcare providers, and I believe I could intuitively feel which one of those would be compassionate.
What's going on there? What's at work in that phenomenon?
You talk about the art of compassion and the science. This is where I sort of like, oh my gosh, my empirical kind of, colleagues are like, ooh, that sounds a little bit, willy-nilly. But there's a capacity within us as human beings to sense danger, to sense compassion, to sense kindness, to sense psychological safety. We know these things, and there's probably sort of scientific indicators that we could pick up on when that happens, but there's still a sensory kind of aspect to that's going on.
Something real is at the heart of this.
Something real, and sometimes the most real things are the things we can't see, the things we can't measure.
We love that saying on this show.
I steal it from the Polar Express, but anyways, but
we take
can call
life
it our
wisdom
own.
wherever we get it.
And so
I love it.
And
from
so
Polar Express.
how do they sense that? And probably the most sort of spine-tingling story that I remember when I was providing psychosocial, spiritual support to a cancer patient who was dying. I was there one afternoon, and in walked a nurse as I was visiting with this person. And the nurse walked in and looked at the patient, looked her in the eye, and smiled from the sort of the foot of the bed, and then walked around the bed and went to the IV pole that was, beeping, and put a new IV bag there, punched a bunch of buttons and reset the pole, was there for probably 30 seconds to a minute. And then as she was leaving, she again sort of turned around at the foot of the bed and just smiled and nodded and left the room. And when the nurse left the room, the patient said to me in a whisper, she said, "I love that nurse." And I was a bit perplexed and probably like a little bit jealous. There was no sort of love for, I was there for 30 minutes. That person was there for 30 seconds. And so I asked her, I said, like, can you tell me, like, what makes you say that you love that nurse? I mean, she was there for 30 seconds. She seemed to be doing a fairly routine kind of monotonous aspect of care. Can you tell me to answer your question, what's going on there? What happened? And I'll always remember the response that she said to me. She said, I can tell by the way that she looks at me that she genuinely cares for me. And so again, to be fair, there's probably some previous interactions where that nurse talked to the person and maybe got to know them. So it wasn't just maybe the first time that person had come in, but there was still something that was conveyed that that person could intuitively feel. And I think the research that we've done in the Compassion Research Lab, I like to say is informed by patients and is intended for patients. It's intended to sort of circle back to them. And the reason I say that is because whether it was that person or whether it was a chemotherapy patient telling me about, I've got the most amazing doctor, and time again, I would ask them in my clinical care, well, what makes your doctor so amazing? And inevitably, again, it wasn't just that they were precise, they were able to diagnose, in an effective and quick manner. Those things are important, to be clear. But they weren't sort of the glory stories, if you will, that made, a good physician kind of move into the category of an excellent physician. It was always when they greet me, I can feel the compassion when they're talking to me. I feel like I know who they are and they know who I am as a person and not simply as a healthcare provider or as a patient. And so those stories, I think, very much inform the work that we've been doing. And I always say, I don't think there's anything particularly novel to the research that we're doing in the Compassion Research Lab. There are novel aspects of developing a valid and reliable measure. But wisdom traditions have told us for eons that compassion seems to be absolutely essential to human flourishing. In fact, if you look at any of the wisdom traditions, Christianity, Islam, Buddhism, across the gamut, if you even look at people like Charles Darwin and Einstein, they all sort of said that compassion is sort of the ultimate outcome of not only what it means to be a true Buddhist, a true Christian, a true Muslim, but a true human being. And so, we take that wisdom and we want to extend that into the realm of science and say, okay, how do we honor that so we don't take away the magic of that sensory aspect of what compassion is? It has to come from who you are as a person, and it has to resonate with me as the person that receives it.
This is Tapestry, your guide to the messy business of being human. I'm Mary Hines. My guest is Shane Sinclair, the founder and director of the Compassion Research Lab at the University of Calgary. The term compassion fatigue is sometimes tossed around. I'm sure you've heard this a lot. Mm-hmm. The idea that people can only handle a limited circle of people and issues to care about, and anything beyond that is just asking too much. Where are you on this idea of compassion fatigue?
So I would say burnout and the phenomena of being taxed and not being able to provide care just due to sheer numbers and patient volumes is an absolute reality. When it comes to compassion fatigue, we actually did a pretty large scientific review a few years ago, just sort of looking into this concept. And I think one of the issues around compassion fatigue that we discovered is that it often implicates compassion as being inherently tiring. And as I mentioned, I think the things that are tiring to healthcare providers are things like moral distress, this idea of wanting to do what's right, wanting to provide compassion, but being unable to do so. And I think the challenge with compassion fatigue is it somehow insinuates that by being compassionate, I am somehow burning my sort of compassionate gas tank. But the evidence as it relates to compassion specifically is actually suggesting the inverse, that it's actually compassion seems to have a sustaining effect on healthcare providers when they're able, and that's the important caveat, when they're able and they're supported in providing the compassion that they want to provide. And there's evidence from even within COVID times, a recent study that, it actually is far more detrimental for us to avoid suffering and to avoid providing compassion to others in the context of the pandemic than it is to be able to sort of be able to express it.
So maybe that phrase needs to be retired. Maybe the phrase compassion fatigue is the problem.
I think we need to put it to bed.
What would you say you've learned about compassion that could go beyond the realm of healthcare? Just something for a random human being out there listening.
I think often when we think of compassion, whether we're working in a boardroom or we're working at the bedside, sometimes we feel that it's sort of like this additional thing that we have to do. And as soon as we feel that, I think we feel tax and burden, and we're like, oh my gosh, like this is something else. But I think what we've learned from talking to many individuals in healthcare, but also outside of healthcare, is that it often involves infusing those small things into routine sort of work that we do that actually make the biggest difference. And so, yes, it does involve sort of going above and beyond the call of duty. But as was the case in that story that I told you of the nurse who looked, it didn't cost, any more time. It was mixed in sort of the everyday routine. Infused.
Yeah.
And I think infusing or stacking compassion into what we already do, I think it just becomes a lot more accessible to us in terms of our ability to actually think, okay, what would that look like if I look at my day from, my waking hours to my resting my head on my pillow? Like, what are the interactions and how can I infuse just a little compassion to that barista that I, talk to every day? How can I do that to somebody that I see on the streets? How can I do that to my colleague? And particularly, I think this is where sort of we move from sort of the basic compassion to the master's level, if you will. It's like, it's really easy to do those things when it's like a barista who's giving me a coffee and somebody that I like at work, a colleague. But then how can I flex my compassion muscles, if you will, to those people that I find particularly challenging? And so I think starting with infusing and stacking it into routine care with people that we interact with on a regular basis, and then from that, sort of how can I extend that outward to individuals that I might find it particularly challenging to provide compassion to.
Has this work changed you?
Yeah, it has. I think all work changes us. One of the things that I think I half-heartedly hoped for in doing this research, and I think this is true of any researcher, is like I want to sort of pin compassion down and, figure out what it is and kind of have some expertise on that. And I think it's like anything. The more that you look into it, you do learn a lot. But you also realize like there are some mysterious elements here that maybe you will understand a little bit more someday. But I think, like any mystery, there are some things that remain unsolved. And I think that is, if you're a person that really needs to know and needs to sort of decode compassion, you might be challenged in that area. But if you can honor those things, I think it actually becomes really, really fun. I think it also keeps you honest, it keeps you relevant to recognize that, yes, there are many, many things and many advancements that we've made in our lab to understand what it is, but to not be so egotistical, to think we've cracked this compassion code, so to speak.
Shane Sinclair, it's really good to talk to you. Thank you.
Thank you so much for having me.
Shane Sinclair is the founder and director of the Compassion Research Lab at the University of Calgary. He's also a professor in the Faculty of Nursing and an adjunct professor in the Cummings School of Medicine. That's it for us this week. This episode was produced by Arman Iqbali and McKenna Hadley-Burke. Technical production by Danielle Duval and Nuruddin Korane. The senior producer is Rosie Fernandez. I'm Mary Hines. Thank you for listening.